And so our next speaker is Dr. Kristen Campbell. Dr. Campbell is a clinical pharmacist at Duke University Medical Center in Durham, North Carolina. And the title of her presentation is Crash Course in Anti-Cancer Drugs. What do they do and what are the cardiac risks?
Thank you. Very happy to be here. I also have no disclosures. So this is obviously a very large topic to talk about potentially all anti-cancer drugs and potential cardiac risk factors. So we are going to do the best that we can to cover big points in the 15 minutes that we have. So we will discuss a little bit more mechanisms of arrhythmias in cancer patients, although we did have a very nice overview. Review common anti-cancer therapies that cause arrhythmias, and then demonstrate the importance of QTc monitoring for some of our anti-cancer therapies. With the progression that has been made in anti-cancer therapy, where we have new drugs or improvements in established therapies, we see a much better prognosis for our patients, and therefore more of our patients will be facing adverse effects of cancer treatment. Our first real cancer cardiotoxicity that was described, I think most of us are familiar with anthracyclines and cardiomyopathy, which was in 1966. But now with so many more new therapies and patients living longer, we are seeing a whole spectrum of cardiotoxicities, and some of those are listed here. Obviously today we are going to be focusing on arrhythmias. When we talk about cancer treatment-induced arrhythmia, or CTIA, there is some discussion of understanding if it might be a primary cause or a secondary cause. So primary is where the drug actually disrupts the specific molecular pathways that are critical for developing an arrhythmia. And secondary cause would be damage to the heart through either ischemia, inflammation, radiation therapy, and that leading to arrhythmia as a secondary phenomenon. The incidence and distinction as far as a cause and effect relationship is often really difficult to establish in this area, and that's because most of our cancer trials do not have adequate numbers to actually look for a true cause and effect of these cardiotoxicities. We also obviously use many multi-drug regimens, and so pointing to a specific medication can be difficult. And then finally, as we've learned, cancer predisposes patients to arrhythmias as well. And this is just another way of highlighting a lot of things that we heard in the previous talk, where we look at all of the different mechanisms for arrhythmias. And so just bringing up some of the other non-chemotherapeutic factors, we have a patient having prior underlying substrate for an arrhythmia, the surgery, radiation, also remembering other medications that we are giving patients. They often are on things like antiemetics that can have issues with arrhythmias. And then electrolyte disturbances from our regimen, so vomiting, diarrhea, those types of things can predispose. Direct cardiac involvement, if it's a primary cancer or a metastatic cancer to the heart, cardiac amyloid. And then effect on cardiac myocytes. So we'll talk about hERG blockade, and then things that we've already talked about with mitochondrial injury and abnormal calcium homeostasis. So when looking at cardio-oncology and the goals that we're trying to maximize for our patients, we want to optimize the benefits of the cancer therapies that we are using, because we do have much greater prognosis, as I already said, but do our best to limit the cardiovascular morbidity and mortality that's associated with these regimens. Over the next few slides, I will highlight a few of the medications and their arrhythmias. I would also like to point you to an article by Fradley et al. That is referenced on some of my slides as well, and Dr. Dent is a co-author on that paper. Most of the chart information that I have over the next few slides is from those papers, and you can find a lot more information in that article as well. It's really excellently written. So first, going through the anthracyclines, the arrhythmia that we see from anthracyclines a lot of times is thought to be likely related to the cardiomyopathy that's induced by the anthracycline therapy. In patients who do develop AFib, which is the most common, then you can see quite a high burden in these patients, so it can definitely limit their quality of life. We do have dexrazoxane, which is used overall to limit the cardiotoxicity of anthracyclines, and that in theory, by limiting cardiomyopathy, could also limit arrhythmias. Cisplatin, the hypomagnesemia that it causes can certainly predispose to arrhythmias. And then we do see a much higher incidence of AFib or SVT in patients who receive their cisplatin directly through intrapericardial infusion or infusion into other serous cavities. So that's something to be aware of if you're using a more direct route. Paclitaxel, the main thing that we see is sinus bradycardia, which can be seen in up to 30% of patients receiving monotherapy. If it's given in combination with cisplatin in particular, then you see an increase in the incidence of sinus bradycardia there. As mentioned, 5-fluorouracil, the main adverse effect of that is ischemic in nature, so angina and MI. But you can see a predisposition to more ventricular arrhythmias because of that ischemic nature of that side effect. Gemcitabine is one that we see relatively common as well. It is definitely more common when used in combination doses, but this is something that you can see even with the first dose of gemcitabine, so something to be aware of very early in a patient's treatment course. Cyclophosphamide is thought to be, any toxicities, arrhythmia toxicities from that are thought to mainly be related to a cardiomyopathy-induced effect of cyclophosphamide. And then melphalan, we see AFib as such a common side effect with this agent that the recommendations are actually that in patients who are at high risk or who have previous known AFib, that before they start their therapy with melphalan, that you have a plan for preventing arrhythmias in those patients, and thinking about, drug interactions and what you will do before you even start the chemotherapeutic plan. Panobinostat is one that has a high risk for QT prolongation, which I'll talk about in another minute or two. But this QT prolongation has been seen so frequently that it does carry a black box warning, and it is recommended that you not administer the drug in patients with a QTc greater than 450 at baseline. And then romidepsin, they did see some sudden cardiac death in the trials, so that is something to be aware of. It didn't warrant a black box warning, but one trial was stopped early because of concern for this. And then the tyrosine kinase inhibitors we learned a little bit about again in our previous talk as well. And alectinib is one that we do have to watch for sinus bradycardia. And ibrutinib, as we talked about, is AFib. And I have just another figure talking about the mechanism of this. And this is the B-cell antigen receptor signaling pathway. And so we have that on target inhibition of the BTK, but you also see off-target inhibition of the TEC protein tyrosine kinase. And these both lead to downregulation or inhibition of the phosphinoinositide 3 kinase AKT pathway, which this is thought to be a critical regulator of cardiac protection in times of stress. And as we've talked about, there is stress from the actual regimen and the cancer, but there also is emotional stress. And so you can see that really playing a big role in a development of an arrhythmia with ibrutinib in particular. And I think we're going to hear more about this in the next talk, but as a pharmacist, I just had to make one direction towards drug interactions. And with ibrutinib, this can be particularly problematic because the incidence of AFib is so high, and there are drug interactions with many of the agents that we would use to try to counteract that AFib. So diltiazem and verapamil can increase ibrutinib concentrations very significantly through 3A4 inhibition. Digoxin, again, you can see an increase in digoxin concentrations, so that is something we need to watch. Amiodarone and dronedarone will also increase ibrutinib concentrations. And then it's beyond the scope of my talk to be able to talk about anticoagulation, but obviously when you have a patient with an atrial arrhythmia, you need to think about anticoagulation, and all of our newer agents, the DOACs, they do have potential drug interactions with ibrutinib that we need to be cognizant of as well. Our chimeric antigen receptor T-cell therapies, they can all cause a cytokine release syndrome, which can lead to hypotension, LV dysfunction, pulmonary edema, all of this leading to myocardial inflammation, which is thought to be the mechanism of how AFib is triggered in those patients. And you can see an incidence anywhere up to 7.5% with any of the agents. And then QT prolongation, so this is something that we have certain agents where we have seen torsades reported, and you can see that list there on the left, and I've already mentioned panobinostat in particular. But then we also have certain medications where they have seen QT prolongation that warrants enough concern to keep it in mind when you're using these therapies. They don't necessarily have a report of torsades, but it is, again, something to be cognizant of. And the mechanism for that, there is potential block of the hERG channels, and arsenic in particular is well known that it blocks both the IKR and the IKS channels, and so that can lead to QT prolongation. Alternatively, we have oxaliplatin, which works on the sodium channels, and you see increased sodium influx due to prolonged opening of the sodium channels, and that can be proarrhythmic as well. And then we have a list of agents that mainly focus on IKR channels specifically, but there is possibility that there are other mechanisms of QT prolongation that still need to be elucidated. So one big thing that is major importance when thinking about this is the oncologists are driving a lot of these regimens, obviously, and oncologists, I think, are put in the position of, semi-becoming cardiologists as well. And so there's a lot of discussion in the literature about accurate measurement of the QT interval and how that is needed, and then guidance as to which formula should be used. And in general, the consensus is that the QTc Friederichia is going to be the best option for measuring the QT interval in patients on cancer therapies. And that is because it is considered more accurate at heart rate extremes as opposed to Behçet's. So we do recommend that formula in particular. And then some general recommendations. So, if you know that you're using a cancer therapy that has QT prolongation or a report of torsades, caution should be used if you have a baseline QT Friederichia of greater than 450. We want to be very aggressive with electrolyte abnormalities and supplementing them appropriately. Managing any uncontrolled cardiac diseases is important, remembering hypertension and all the things that were on one of my earlier slides. Trying to avoid use with QTc prolonging medications that can be quite difficult in cancer management, as I mentioned, with things like antiemetics, but doing the best that can be done. Monitoring EKGs at baseline and then routinely throughout cycles, and it will be specific to that chemotherapeutic regimen and when those drugs that I've mentioned are being administered within the cycle that you would want to get that monitoring. And then again, we can't emphasize enough the monitoring of the electrolytes prior to initiation, the beginning of every cycle, and periodically in between if needed, if the patient has demonstrated significant disruptions in their electrolytes. So in conclusion, we're seeing increasing recognition that some cancer treatments can have significant electrophysiologic effects. Close monitoring is always warranted, and something that we'll kind of lead into with our last talk and hopefully through the questions is the importance of a multidisciplinary team to tackle all of these challenges that we have when managing our oncology patients. Thank you.